Surgery, MS at Kottayam Medical College, and Super Specialty in Plastic Surgery from PG IMA Chandigarh. He is specializing in micro and reconstructive surgery, hand surgery, aesthetic surgery, and craniomaxillofacial surgeries. Over to you, Dr. Naveen Isaac.
വേണ്ട സാർ ഇതിൽ ചേഞ്ചിങ് ഇതിൽ ചെയ്യണം പോയിന്റർ ഇതിൽ യൂസ് ചെയ്യണം സാറിന്റെ പ്രസന്റേഷൻ
This leads to a drastic fall of fluid in the intravascular compartment, leading to hypotension and shock, which is called as a hypovolemic shock. This happens in the initial period, and later there is extravasation of larger molecular substances like proteins also. So what has to be done at the site of incidents? The primary aim is to save the life of the patient. So the first thing we have to do as a first aid is to move the patient away from the source of burns. And the first aid, which has been emphasized again and again, is to pour plenty of water over the burns. We have seen patients coming after applying toothpaste, butter, ghee, chicken fat. All these are not advised, because these things as such are not sterile and they can result in secondary infections. And another thing is that when they apply these things and come to us in order to see for the depth of the burns or assess the wounds, we again have to clean all those things, which can again lead to further aberrations and increase the depth of the burns. So observe and record any clues at the site, arrange to shift the patient to any medical facility, record history from the patients, and if the patient is critically ill, obtain a dying declaration there itself. Do not give food, and most importantly, never sedate the patient. So if the patient is the first hospital where the patient is taken is not a referral center or a primary burn center, there are certain criteria which are indicated where the patient has to be shifted to a specialist burn center, which includes burns more than 10% in a pediatric patient or more than 15% in an adult. Burns of the critical areas like hand, feet, etc. Third-degree burns, electric, chemical, or inhalational burns, any pre-existing medical conditions or any other comorbidities, and burns in children where the specific pediatric care is not available. So the initial assessment in the hospital is again the basic for all traumas, which is the ABC, establishing the airway, the breathing and the circulation, followed by exposure of the patient to see for all the injured sites, inserting IV cannulas, Foley's and nasogastric tube to administer fluid to the patient, and search for any associated injuries. Once the initial evaluation is over, the patient is again examined in detail, where a detailed history is taken, any paperwork is seen, other occult injuries are ruled out, investigations like blood investigations or X-rays are carried out. Photographic documentation is a must, because almost all burns are medico-legal cases. Once we have seen this, the next is the local examination of the wound, where we have to see for the extent of the burns and the depth of the burns. The extent is calculated by the commonly used rule of 9 of valleys, or the London Browder chart, which is even more specific. The depth varies from first degree burns to second degree to third degree and to fourth degree. So depending on the initial presentation or in the, later the color and the sensations, we can come to a conclusion about the depth of the burns. Fluid resuscitation is the core of burns resuscitation. So as I told before, burn size more than 10% in a pediatric patient or more than 15% in an adult requires fluid resuscitation, because the oral fluid that you give is inadequate and intravenous fluid administration is required, and hence these patients or children needs admission in a burn center. So if you, Jackson has divided the thermal zone into 3 zones: the zone of coagulation, stasis and hyperemia. Coagulation is the central zone, which is already dead. The stasis zone is the middle zone, which can go either way. And the zone of hyperemia is going to be saved. So our aim is to convert the zone of stasis into a zone of hyperemia. So if you are not going to resuscitate this patient, the zone of stasis is going into a zone of coagulation. That means the size of the burn is going to increase, which can increase the morbidity as well as the mortality of the patient. A number of resuscitation formulas are there, but the most commonly used and most widely used all over the world is the Parkland formula, which is 4 into percentage burns in the weight of the patient. And the calculated amount is given as in 2 unequal halves. The first 50% in the first 8 hours and the next 16% in the next 16 hours. This is because the fluid requirement in the initial 8 hours is the maximum. And but to date, none of these fluid formulas are perfect. So these fluid formulas are just a guidelines to initiate your fluid resuscitation, and it is the clinical indicators like your pulse rate, cardiac heart rate, etc., which has to guide you forward. And of all the clinical parameters, urine output has been found to be the most reliable, reproducible clinical indicator. And our aim should be to maintain the urine output of 0.5 to 1 ml per kg per hour for an adult and 1 to 1.5 ml per kg per hour for a pediatric patient. Infections are the next problems which can arise in burns as the burns days goes forward. So in the initial itself, you give a tetanus prophylaxis and the antibiotic. The first two to three days, you may not require antibiotics, but after that, you will require intravenous antibiotics to be given to the patient. And initially, you start with a lower antibiotic, and the later antibiotic are guided by the culture and sensitivity. And sepsis can be found to be the most frequent cause of death in burns and contributes to almost 75 to 85% of all the deaths. So this is what I told, the organism, according to the culture and sensitivity, you can titrate your antibiotics and antifungals accordingly. The topical antibiotics, it has been found that the systemic antibiotics may not reach the site of burns in all patients. So the topical antimicrobials has important role to play. Antiseptics like betadine, all these things help. But the major milestone in a topical burns therapy was the discovery that silver has a very wide action against many of the microorganisms, which including microbes, virus, protozoans. And initially, we had silver nitrate, silver sulfide icings, and the next generations like colloidal silvers, nanocrystalline silvers are still available. Silver with collagen and even silver impregnated dressings like Acticoat, Mepicil AG, etc., which can elude the silver for a prolonged period, varies from 3 to 5 to even up to 7 days. So the advantage is that you can keep the dressing, and you need only dressing change maybe once in a week, provided it is not an exudating wound. So this is a pediatric, but this is very useful in pediatric patients because each dressing change is a painful episode for the patient. And if you are treating the patient on OP basis, this patient has to travel to you each time for the dressing changes. So this Acticoat dressing, if you can apply it on, apply for the pediatric patient. So it has been found that you need to change the dressings only once in a week. Collagen has another important role because they increase the cell proliferation, angiogenesis, and collagen deposition. They are transparent and allows for wounds inspection. The collagen dressing is the differentiation is that collagen dressings has to be applied in the first 24 hours or the maximum first 48 hours. If the child presents you late or if the wound is infected, you are not supposed to apply collagen dressings. And because it is a transparent, you can inspect the wound daily. And since it is a sheet, it covers the nerve endings, so it is less painful for the patients. The goal of a burns dressing is to prevent infections, promote epithelialization, and avoiding water and heat loss. And recently, biological dressings like allografts, skins, xenografts, and human amnion has been extensively used. So this is a patient where we have used an allograft. It's a child who presented with third-degree burns over the face, over the trunk, and upper limb. So in the initial picture, we had debrided and we made sure that it has gone to the healthy tissue, and we got cadaver skin from Coimbatore, and we have applied the cadaver skin over the cadaver skin get rejected in around 5 to 7 days, or maybe for pediatric patients they stay for some more time. And after that, once the wound has the infection gets controlled, and once the granulation appears, you can go for an autografts. So this is a final picture where the autograft has been applied in the child. The surgery for burns started even in the 16th century. but it was not until the tangential excision was discovered by or brought forward by Jankovic that early excision became rampant. So before taking a patient to a surgery, we have to optimize the patient, arrange adequate blood and blood products, and you can do a tangential excision or serial excision. Tangential excision is where you excise the skin layer by layer till you see bleeding, healthy bleeding tissues, and you place a graft over that. Serial excision, where you take the patient in multiple stages, not in the single sitting, but on multiple days. On the first day you may take, but if you are not sure whether it is a healthy wound, you can take the patient maybe after 2 days to see for the wound and again do a excision, and then you place the graft over that. That is a serial excision. So this is a patient where we had done a serial excision. We divided it in stages and we finally placed a graft over the wound. These are just representative. I think Dr. Heyman will be showing more cases to you. So this is again an electrical burn. The problem with electrical burns is they don't demarcate immediately. They take time, 1 week, 2 weeks or more they may take. So they keep on extending. So we keep on debriding the wound till the wound is healthy, and then we go in for a grafting. This is again the wound over the leg in the same patient, but you can see that the bone is exposed. You cannot graft over that. We had to do a free tissue transfer. Adurolateral thigh flap was taken, and we had transferred sutured, anastomosis with the popliteal vessels in the same side. So this is the final result. We are not always we are lucky. This is a burns, the same patient where there was a deep burns over the hand. In the initial stage, we did a liberal fasciotomy of the fingers, of the palm and all that. But as I told, this keeps on progressing. The vessels got thrombosed and finally we had to go in for an amputation. So with the advance in tissue engineering techniques, skin substitutes became a prominent factor in burns healing and research. Materials like Integra, Metriderm, Appligraft, all these have been has been started. We have even started using these products. The supportive treatments like ventilatory management, physiotherapy, psychological support, diet management, pain management, all these are very important for a burns patient. The complications can be early and late. The early, which includes a plethora of problems like shock, infections, hypothermia, curling ulcers, septicemia, organ failure, deep vein thrombosis, and psychological trauma, etc. So patient needs support at each stage of this. And late problems like scarring, pigmentation, contractures, marginal ulcers, etc. can happen. Secondary surgeries may be required immediately if your surgery is partially or completely fails, like there is a partial or complete graft failure or there is a flap loss. You may have to do secondary reconstructions for that, or delayed when the patient goes in for a contracture, scars, pigmentations, marginal ulcer, etc. This patient presented to us very late. She came with a severe contracture of the neck, and you can see the chin almost sticking onto the chest of the patient. So we did a complete release of the wound, did a skin grafting of that, complete release, and we skin grafted that area. So this is a final result where she was a very happy patient. She could extend the neck completely. The same patient with an elbow contracture, again, which was completely released and skin grafted. Another case of, not all patients require skin grafting here. Z-plasty or an Z-plasty was used in parallel to release the contracture. Again, this is an unstable scar. This patient had recurrent breakdowns of the scar. It was the previous burns which should have been grafted but was not grafted, allowed to heal spontaneously. The patient presented with recurrent non-healing ulcers which are again excised. The unstable area was completely excised and grafted. This girl presented with a scar over the chest and breast region. So we placed an expander in the tissue expander in the upper part of the chest and the neck, and the expanded skin was used to cover the. We excised the scar, and the expanded skin was used to cover that area. So, in summary, burns treatment has advanced very significant over the last 75 years or more. And small burns can be treated anywhere, but large burns require specialized care, and such patients need to be referred to dedicated burn care facilities at the earliest. The mortality of severely and extensively burned patients has significantly decreased due to the improvement in infection control, early resuscitation, improved surgical approaches, and other treatments, basing on the better understanding of burns pathophysiology. And preventing burns complication is always better than treating them. Thank you. So this is a Burns team of Jubilee Mission Medical College. Thank you. Thank you very much.
Thank you, Dr. Naveen, for that excellent talk. We'll postpone the discussions and the doubts clearing to the last. Now I invite Dr. Hemang A. Sanghvi to the stage. Dr. Hemang Sanghvi is currently working as Assistant Professor in the Department of Plastic Surgery and Burns in Jubilee Mission Medical College. He did his MCH from Bangalore Medical College and Research Institute. His special interest is in aesthetic surgery and burns. Today, he'll speak to us on the management of burns, a case series from his hospital. Dr. Hemang.
Case series. Research suite. This benefit. Which button? Slides. Slides from here also, no? Here also I can, no? Yeah. You can change slides to from here, no? Okay. This one is for pointer. Pointer. Okay. Good evening, and thank you, ma'am, for giving me a wonderful introduction. So, topic today given for me is management of burns case series in our hospital. So for any burns management, the goals of treatment needs to be considered. First goal is to initially to control pain, to remove that tissue, to prevent the infection, and to reduce the scarring risk, and to regain the form, function, and aesthetic outcome. So initial management, whenever patients come in casualty, initial management is always ABC, airway, breathing, circulation. Then history taking is more important. Onset, duration, progress, time of burns. In female patient, marriage history, number of children, LMP is taken for medical legal purpose. Then the depth of burns needs to be assessed, extent of burns, and pathophysiology, which I will discuss in later slide. So this is the degree of burns. First degree involves just the epidermis. Second degree, it is further characterized into superficial and deep dermis. Third degree involves up to subcutaneous tissue. And fourth degree, it involves the muscle, tendon, nerves, and bones. So this you can see first degree burns, it is just erythema. The next is the second degree. It is second degree burns is characterized by moist, it is moist, erythematous, painful, blister formation, and it will blanch on touch. Third degree burns, it will form a hard leathery ash scar formation, and it will not blanch on touch, and it is less painful compared to the second degree burns because the nerve endings are destroyed. And fourth degree burns, it totally charring of tissue occurs, such as in the case of the electrical burns. So I'll skip this slide. Already Naveen sir has already discussed rule of 9 Wallace formula. So fluid resuscitation, Parkland formula, which is commonly used, percentage of burns into body weight into 4. In this formula, first degree burns is not calculated, and maximum percentage of burns we can take as 50%. Even in patient with 100% burns, 50% burns, 50% is calculated in this formula. Whatever the amount comes, it is in ml. So first half is given in first 8 hours, next half in next 16 hours. And then depending on the urine output, you have to titrate the IV fluid. already discussed, so I'll skip this slide. So first degree burns management, there is no need for dressing. You can give some topical emollients and painkillers to relieve the pain. And it can be managed on a OPD basis. Second degree burns, it requires daily dressings with some topical antibiotic creams, which I'll discuss later. Some either temporary, biological, non-biological, synthetic dressing to close the wound. Deep second degree and third burns requires early tangential excision and grafting, which I will discuss later. So in case of circumferential burns, like third degree and fourth degree, there will be hard leathery eschar formation, and sometimes the distal periphery, there is compromise of the circulation. For that, you need to do a eschartomy. So these are the markings for the eschartomy. On the hand lateral, from the lateral region, you have to go down on the radial side up to the thumb. For leg region, on the lateral side. So what are topical antibiotics which we use in burns patient? Silver sulfide now second generation, third generation has come up like nanocrystalline silver, colloidal silvers dressing. The previous silver sulfide that has a problem, it would not penetrate the skin and it will form a hard leathery eschar. So it was difficult to delineate between the normal eschar and the pseudo eschar because of silver sulfidizing. The other is mefenide acetate. It's a broad spectrum. It penetrates the eschar. It can be used against Pseudomonas and Enterococcus species. Neosporin, bacitracin, and polymyxin B. It is bactericidal and it helps. It has a limited eschar formation. Mostly used in case of facial burns, graft size, and case of partial thickness burns, small partial thickness burns. Silver nitrate, previously it was used, but now it is outdated because it stains the contacted area and it causes methemoglobinuria, and there is chance for hyponatremia. Dakin solution, sodium hypochlorite 0.025%. It is effective against all organisms, but it mildly inhibits epithelialization. Acetic acid, you might have seen that it is used against Pseudomonas infection. Systemic antibiotic is not the rule. Initially, the wound is sterile for 2 to 3 days. But if the patient hygiene is poor, patient can be started on broad spectrum antibiotics. And in patient with over 30% burns, prophylactic antibiotics can be given. And depending on the culture sensitivity report, after third day, we can start the antibiotics. So what are the skin substitutes? Biological, you have human allograft from cadaveric donor, which is available from skin bank, amniotic membrane, then xenograft from either bovine or porcine skin. Then synthetic, we have collagen, opside dressings, and combined biological and synthetic, which is newly come up, like BioBrain, Transite, Integra, Allodum. Then cultured epithelial, epidermal autologous cells. Epidermal cells is cultured in vitro from murine fibroblast. Non-biological dressing used in case of second degree superficial one like gauze, fine mesh gauze, occlusive hydrocolloid, contact layer dressing or semi-polyurethane film or calcium alginate dressing. And topical enzymatic debridement, collagenase, papinuria and papain. So we'll come to the case series. This was the case of second degree burns. We have used in this case of nanocrystalline silver. Along with that Bactigras dressing, which is chlorhexidine impregnated gauze, and along with that melanine dressing. Melanine dressing is a highly perforated polyester film with the highly dense cotton inside. It is non-adherent dressing, so pain is less while doing the second dressing. For mild to moderate exudative wounds, melanine dressing can be used. So second degree burns, another case, managed with Acticoat dressing. So it has silver ions, and we have to charge with distilled water before applying on the wound. The advantage of this Acticoat dressing, it can be kept in the wound for 5 to 7 days, only needs to be inspected, and no need for repeated dressings. Another case managed with collagen dressing, second degree burns, which is characterized by erythema, moist blister formation, blanching on touch. And before applying collagen, it is a preservative, so it has to be washed properly with normal saline, and within first 24 hours, it has to be applied on the wound. And advantage is that we can easily inspect the wound and there is no need to change the dressings. So mostly used in case of pediatric burns. Another case, this is Mapilex AG, also called as silver foam dressing. For mild to moderate exudative wounds, silver foam dressing is used. Advantage is that it can soak the, there is chance for infection exudate. The exudate will not penetrate the wound and it will be absorbed by means of this Mapilex. Another case, allograft dressing. In case of patient which has extensive third-degree burns where the donor sites are limited, temporary skin like allograft, which can be procured from skin bank, it is applied on the wound and for 7 to 10 days. Once the wound epithelialization and granulation occurs, then we can do the skin grafting, autograft. This is the dermal regeneration template, which is newly used in case of burns. The advantage is that in case of contextual release, there is high chance for post-operatively hypertrophic scar and keloid formation. So with the help of dermal regeneration template, the elasticity of the skin and keloid and hypertrophic scar can be reduced. Disadvantage is that it is costly. So this is another case with deep third-degree burns involving the neck, chest, and axilla. So early tangential excision, layer by layer, up to the bleeding age, and followed by skin grafting was done. So axillary contracture, there are various options for treatment options available, like contracture release, SHG, Z-plasty, a local flap, latissimus dorsi, parascapular flap, tissue expander, the integra, and SHG. This is the case which a patient had anterior fold axillary contracture. A multiple Z-plasty was done and patient has full extension of hyperabduction of 110 degree. The another case where local flap was planned and multiple which flap was planned and it was inserted into the anterior axillary fold. The rest area was skin grafted. Post-operatively, proper splinting is done for at least 2 to 3 months to avoid the recurrence of the contracture. Another case of axillary contracture where a square flap was planned. So on one side, the square is marked and the opposite side with the 45-degree angle, a triangle is marked. In the right angle triangle is marked and the flap is inserted into the axillary floor and the rest area is the triangle flap inserts. So this was the case of neck contracture, band contracture, where contracture release and skin grafting was done. Another case where patient wanted aesthetic appearance of the neck. So the normal skin, we inserted a tissue expander and then it is done in 2 stages. It is slowly inflated and over a period of 6 weeks. And then the normal skin is advanced on the after excising the scar tissue. Another case of neck contracture, band contracture, where Z-plasty was planned, and this was the elbow contracture where trapezioplasty was planned. In this, the square flap is marked on one side and the opposite side, single line is drawn and vertical so that this flap sits on the joint region. Hand contracture already discussed, Z-plasty, multiple Z-plasty. In this case, we have to see whether there is an intrinsic contracture or extrinsic contracture. We have to take the X-ray and see whether the joint is supple. Depending on that, if there is just extrinsic contracture, then we can just go ahead with the Z-plasty. Another case, patient neglected wound, managed outside, and patient developed contracture of the thumb. And on examination, joints were supple. So we did a just contracture release and the flap was inserted on the proximal metacarpophalangeal and the distal interphalangeal joints. And the rest area was skin grafted. K-wire is inserted just for temporary for 10 days until the graft is get stabilized. Post-operatively, proper splinting is done in hyperabduction and extension position for at least 3 months to avoid the recurrence of the contraction. Another case, patient had severe contracture of the 3 fingers, middle ring and little finger, where contracture release and skin grafting was done. Full thickness skin grafting is preferred. This was a case of electrical burns, had severe contracture of his all four fingers, where contracture release was done and groin flap was planned to avoid the recurrence of contracture. So to conclude, wound dressing approaching ideal wound characteristics should conform to the site of wound, should alleviate pain, promote faster healing, and attempt to restore patient normal daily activity. And early tangential excision and grafting decreases hospitalization, lower the hospital cost, decrease hypertrophic scarring, and increase survival of the patient. And proper splinting during the wound healing helps in preventing contracture and prevents further post-burn deformity. Thank you.
Thank you, Dr. Hemant, for sharing with us all those around 20 cases in his hospital. Next, I invite Dr. Pradyut KM for his talk. And Dr. Pradyut Korambail Mugundan is a professor in the Department of Plastic Surgery and Burns, Jubilee Institute of Surgery for Hand, Aesthetic and Microsurgery, Jubilee Mission Medical College and Research Institute, Thrissur, specializing in hand surgery, burn surgery, and microsurgery. He is interested in research on hyperbaric medicine and its application in plastic surgery, particularly in burns and trauma. More specifically, his work examines the utility of hyperbaric medicine and its function on the molecular level of wound healing, which helps in all spectrums of plastic surgery. He'll be sharing with us a few insights in his research on burns. Over to you, Dr. Pradyut.
Good evening, all. Thanks for the introduction, madam. I just shown this figure as a banyan tree. Yes, we are the third generation plastic surgeon. The plastic surgery started in Jubilee, initially by Dr. Idanwala and Dr. Narayan team. The second team was Dr. Prashant, and the third team or our generation of Dr. Naveen and Dr. Hemant and myself. We are almost like the prop roots of the banyan tree. I will just share our own experience while having through this travel. Initially, the plastic surgery evolved as a cleft lip and maxillofacial surgery. And later, the burns was evolved and hand surgery, microsurgery, microneurosurgery, craniofacial reconstruction, aesthetic surgery, and research has developed simultaneously over a period of 13 years. This is a burns data. This much of patient we get in a year. Due to COVID, there was a decrease in number of burns, and most of the burns was not admitted. They have been sent to the home as by assessing the severity. And we have about 600, and an average of 600 cases in a year. Now, when it comes to the burns wound is mother of all wound. Whatever we do in a general practice or some other practice, the common application will not come to into the criteria of the burns. Burns gives the insight into the further depth of the healing. The first thing which we see in the burns is the systemic inflammatory response. Even a 5 to 10% of burns which affecting the hand, the patient will present like a systemic inflammatory response, which is almost proportionate to that of the COVID. And the second thing which we see is the tissue edema. There is a fluid shift from the intracellular volume, extracellular volume, and the total body volume. And this fluid shift is sometimes dangerous because this will cause imbalance, intracellular volume loss, which may lead to the death of the cells. The third thing, most of the surgeries when we do on the head and neck, we just go for giving a steroid. But in burns, steroid cannot be used because the wounds will not heal because if you are going to provide a sufficient amount of steroid. So immunosuppression cannot be used very liberally in burns. And most probably it cannot be used at all, actually. The fourth thing which we see is the compartmental syndrome. It is not the compartment syndrome as that of the bony fractures or something like that. This is a compartment starts from the skin. It is not from the deeper tissue. And the fourth thing is in this, something a term is called as an inflammatory edema. It's not an infective edema. It is a term is called as an inflammatory edema. The edema caused due to the inflammation. It is not infected actually. We have to sort out these things first to know completely about burns. These are the things for going into the research. We must know some basics. I'm just dealing with some basics. The first thing is the area of necrotic tissue, which requires definitively a surgical debridement or a surgical treatment for this area. The second area is called as a marginal tissue area. This can become this if not treated properly. This marginal area is preserved by hyperbaric oxygen therapy, which I am going to discuss in detail next. The third area is a normal tissue area. As Dr. Naveen explained about, our primary criteria is to shift this area to this area and this area. We have to shift the normal tissue towards up. If the treatment is not adequate, this tissue will become penetrating into the marginal area and then into the normal tissue, which becomes very dangerous. Another thing which we have to understand about the burns is, first, the ischemia occurs in the primary area. Then there is increased capillary leak, which causes an edema following capillary leak. And again, it causes secondary ischemia and it goes in a circle. So then the compartment syndrome is formed. When there is an inflammation and edema, then if the pressure increases, it goes, if the intracompartmental pressure of the intracellular compartment pressure increases, slowly it will go for a venous congestion. And when the venous congestion is so profound, then it will go for an arterial insufficiency. And what the hyperbaric does is it initially controls the inflammation edema and supplies the oxygen to the inflamed tissue. Hyperbaric oxygen chamber is this is the first chamber in South India, which is installed in November 11, 2011 by Dr. Prashant Worki, and it was inaugurated by an ambassador of Prasad, where this chamber was made in Peru. This is our own data on hyperbaric oxygen therapy. We have already done about 10,000 sessions of patients, and most of this hyperbaric is used in the burns. You can see this spectrum of around 39% of the injuries which has been used for hyperbaric is of burns. Now, what is research in burns? It is very significant. The topic is so significant that everything which we treat in burns as a component of research in it. The first thing is the fluid resuscitation, which is now usually countered by the Parkland formula. The problem with the Parkland formula is we don't know the amount of fluid we are going to instill. So we must measure the amount of fluid dynamically to understand how much of the fluid has gone inside the body, how much of fluid is there in the total body volume, how much of fluid is there in the intracellular volume, and then how much in the extracellular volume. Yes, hyperbaric acts here by stabilizing the membrane of the cell so that it prevents the leakage of cellular fluids. The second thing is research in wound assessment monitoring. Wound assessment is either done by clinically. Now in our department, we use indocyanine green assessment and then infrared camera to understand the depth of the wound. The third thing which we do is wound management. The first thing we have to worry about the dressing materials which is used for burns. Dr. Hema has described about the malolent dressing material, which is a 3-layer dressing material, which absorbs lots of fluid so that there is no stasis of the fluid onto the wound and there is no infection stepping on. The other thing in the wound management which we think about is a local and systemic antibiotic. Now, due to the systemic antibiotic resistance, we have to more rely on the local antibiotics, and the number of local antibiotics available for these burns tissues are very less. And hyperbaric oxygen will supply the oxygen and it prevent the anaerobic infection, because in the oxygen environment there is no possibility of anaerobic infection there. And the fourth thing is about the surgical correction. When you go for the surgical correction, hyperbaric is always help in diffusion of oxygen to the skin graft and the flaps, which is required for burns surgery. When you come to the fluid resuscitation, the first thing is the assessment of fluid. This is a machine called as a body stat, where it understands about, it measures about the total body volume, extracellular volume. And with measuring total body volume and extracellular volume, we can just minusing extracellular volume from the total volume, you can understand the intracellular volume. This is a machine which is placed along the side of the patient. It is not an invasive method, it is a non-invasive method. 2 electrodes are placed, and with placing these electrodes, one on the hand and one on the foot, we can understand the total body volume of the fluids. And if you are keeping the electrodes in different positions, we can see a compartment analysis of the fluid which is in particular area. This was made into, most of the things are made into publications. The management of wrist electrical burns with relaxation modalities with better functional outcome has been used by means of the body stat, hyperbaric, and the dressings used. Next comes the wound assessment. When you go for the wound assessment, indocyanine green is being infused into the body, and then the level of perfusion. This is a perfusion by it indicates a perfusion of indocyanine green. There is a fluorescent color mark, and it means if the perfusion is there, the burns is not much deep, it is superficial. If the perfusion is less and totally absent, then it indicates that there is a 3rd degree burns. We have made it into a publication in Indian Journal of Burns. This is one example for infrared thermography, where we use infrared camera to take photos. These areas, there is a measurement of parameters here. If the color of the wound is blue, that means the perfusion is inadequate. It means a deep burns. If the perfusion of yellow, it is around red, minimal red or something like that, it is normal tissue. And if the perfusion is more as if it is an inflamed tissue, it is a little bit white. By using indocyanine green, when you infuse indocyanine green into the blood, this goes into the blood, it goes and shows up the areas which is deep. When you are taking infrared camera, it takes a picture from above. This is skin surface. Indocyanine green is perfused from below, and we can understand the depth of the wound here. And infrared camera is taking the picture from above, and we can understand the perfusion. By showing these two things, we can understand how far the perfusion is happening, how far we have to go surgically excise this wound, because most of the time when we excise the wound in the surgery in burns, we may go in an extra proportion, so that the normal tissue also taken away from the during surgery. This is one of the equipment which is very useful. You make an there is a probe which is attached to the body, and will measure the oxygenation of the tissue. It is not oxygenation of the capillary filling or something like that. It measures the oxygenation of the tissue. It's particularly useful in the electric burns, where we keep this electrode and find out whether the vascularity is adequate to do any procedures on them. And this is the method which we use in our Jubilee. First, we will see the body stat, access the fluid perfusion in this area, and then we go for this one infrared thermography to assess the surface temperature, and we go in for the indocyanine green to assess the perfusion from below, and we measure the oxygenation of the limb, whether we have to go ahead of a procedure or not. And to increase the oxygenation of the particular wound, we give an hyperbaric oxygen therapy. This is one of the pictures showing pictures of infrared thermography, which has been taken in sequence. It was taken in day 1, day 4, day 6, and day 8. This is for the child. In this finding, in this article, we found that the wound has healed within 8 days while using hyperbaric oxygen. We just made a two study, one with 10 patients of hyperbaric, 10 patients with hyperbaric and 10 patients without hyperbaric. We found that the patient subjected to hyperbaric has healed within 7 days, rather than the patient without hyperbaric has healed within 21 days. Though this means there is a reduction of a period of 7 to 21 days, that is 14 days. In this time, the patient will have the wound infection very commonly. Then coming to the wound dressing, yes, as Hemang said, we used a malolin dressing, and most of our dressing is a full body dressing. We cannot spare, sometimes it is in 90% burns or something like that. In this wound, when we particularly keep it in the neck control, it absorbs full of the fluid, and the patient will not have a smell during there is a seepage of fluid or something like that. It can be prevented actually. What is the research in it? Yes, we have used a grape seed extract or a tamarind seed extract, curcumin extract or a cardamom extract, which can be coated on the dressing material, and which can use to prevent the antibiotic resistance in case of applying for systemic antibiotics. This is our own Jubilee initiative, tissue engineering, where we made a placental extract of amniotic membrane, which has been freeze dried, and it was kept on the 2nd degree burns on pediatrics. It helps very well to heal the wound. When we come to surgical innovation, yes, we use a perforator flaps for wrists. So that this perforated flap, for the survival of the perforated flap, you use an hyperbaric oxygen therapy also. This is consolidation about the burns. We use this hyperbaric to give oxygenation to the inflamed tissue. We use proper dressing material like meloline and antibiotic coated meloline material for dressing. We use transcutaneous oximetry to measure the oxygenation of the tissue. And we use an indocyanine camera to assess the perfusion of the area, infrared to understand the surface temperature, biostat to understand the fluid volume of the patient, amniotic membrane for healing the patient. And there is another material called fibroseal, which is a material which is used for sticking the skin graft to the bed like a thrombin material. And we use some lipoaspirates to form the cell on the dermal template also. This is some of the clinical trials which is going on in Jubilee. One of the trial right now we are using is we are identifying the IL-6 genetic level IL-6, TNF alpha and IL-10 for the patients to identify the therapeutic window where the treatment can be given in the phase of septicemia. Particularly if a patient is coming with the pediatric burns, we will be just measuring the IL-6 proteins levels usually. But this examination does IL-6 level at the genetic level expression. So before it comes as a protein, it expresses in the blood like a genetic level expression markers. If these markers can be identified early, we can change the course of the treatment and the therapeutic window of rescuing a patient will be increased. Another study is done in general surgery. It has been done for septicemia in patients with abdominal sepsis. We do the same markers, understand the same markers, how the levels of markers are increasing. If the levels of markers are increasing genetic level, we may change the course of the treatment to get a better therapeutic window for this patient. Not only going about the surgical or hospital part, we have also made our own van to reach the patient to the home to do dressing in most of the problem, as Naveen said, Dr. Naveen said, the most of the major problem which we face with the burns is the continuous dressing. If we can send a van to these areas in a particular direction, we can right now treat these patients. And we are designing this in such a way that one van goes towards Palakkad one time, and one van goes towards Irinjalakuda, and one van goes towards Kunnangalam. The patient who are present in all this area, we go just cover up and do the dressing and take the photographs of the wound so that we can assess the infective status of the wound. And then if the wound is infected, we can bring the patient in the same van to the hospital. Right now, this is made as a project with the South Indian Bank. We made a solar electric car so that we go to this area within 70 kilometers of Jubilee. We go to these patients and reach out to them to do dressings and all. This is an innovation which is made for reaching out to the patient to get the dressing material in this to manage these complicated wounds of burns. Welcome to visit our burns unit. This is a newly inaugurated burns unit with a 5-bedded ICU and 1 bed for palliative care and 1 hydrotherapy unit inside the burns unit. Welcome all. Thank you.
Thank you, Dr. Pradyot, for that excellent talk. I now invite Dr. Akhil Paul onto stage. Dr. Akhil Paul completed graduation in 2011 and MD in Pulmonary Medicine in 2016 from Christian Medical College, Vellore. He also completed integrated postgraduate diploma in Family Medicine, postgraduate diploma in Diabetes and Renal Management, and postgraduate diploma in Advanced Cardiology and ECG. Presently working as a consultant pulmonologist of MOSC Hospital, Kunnamkulam. He'll be speaking on the topic of muscle loss, the new challenge in clinical practice. Over to you, Dr. Akhil. I need to mention that Dr. Akhil was the captain of IMA District Committee Thrissur cricket team.
Good evening all. First of all, let me thank IMA Thrissur and the sponsors for giving me this opportunity. And thank you, ma'am, for those kind words. So we had intense sessions on burns. I won't take long. Just here to give some facts about the muscle loss, which is different from the burns, and why we all need to have an adequate muscle mass, and our patients also should have, to decrease the morbidity and mortality when we are hit by any of the diseases. So globally, the population is aging because of the better medical care and facilities. And it is expected that between 2015 and 2050, the proportion of population above 60 years will almost double. And 2015 is 12%. By the end of 2050, it will be 22%. By 2020, the population above 60 years of age will outnumber the children which is younger than 5 years of age, because the entire population is towards the aging trend. In 2050, 80% of older adults will be living in low and middle income countries. The pace of population aging is much faster than the past. So, all countries face major challenges to ensure their health. Now, in coming to India, when we compare 2021 and what we are expecting in 2031, there will be around 41% of increase in the population and the population, and thus it will result in the aging population also. So when we say the age of our population is going to increase, that means, as the subsequent slides will show, that the muscle mass will decrease by age, so that muscles are going to also going to get affected. When we compare men and women, we can see that men on an average is supposed to have a better muscle mass when compared to women, and both sexes will have a deteriorating trend in the muscle mass as the age goes by, and the proportion of loss is almost same. The rate of loss is almost same. When we compare the lower body and the upper body, lower body will have a better muscle mass, but the rate of deterioration of the lower body is much more than that of the upper body as age progresses. When we compare the muscle mass, the lower body mass of age 25 versus age 63, the muscle mass will decrease and most of it will be replaced with fat. So when we say protein will be replaced with fat. Again, by about 45 years of age will maintain the muscle mass, and then from 40 to 70 years of age overall we'll lose around 1/4 or 24% of the body muscle mass, and from 70 years onwards every year we are going to, every decade, every 10 years we are going to lose about 15%. So previously the muscle mass, the loss of muscle mass is called sarcopenia, and previously it was considered as age-related loss of muscle, but now it's not just age. Chronic diseases, physical inactivity, impaired mobility, and malnutrition all can contribute to loss of the muscle mass. And now WHO has recognized it as a disease, sarcopenia, and given a code for that. In India, a study shows that men is having 47% of men is having lesser muscle mass, which is required for that his own weight, age, and height. And women, it's much lesser, but it's still 24.5% of women are having sarcopenia. So what causes muscle mass loss? Because we can have sedentary behavior, the environmental factors, the inborn factors, and our physical factors also can contribute to that. For example, it can be immunosenescence, sedentary behavior, decrease in the motor units by number, or changes in the hormone levels, altered proteostasis, increased inflammation, malnutrition, chronic diseases, and many more. So in the early life, there's a maximum peak of muscle mass. In the adult life, we'll maintain it, and the elderly life will lose it. So what we can do is, in the early life, we should build our muscle mass. In the adult life, we should maintain it by adequate nutrition and exercise. And when we become older, definitely we'll have loss, but we can decrease the rate of loss, or we can decrease the quantum of loss by continuing the exercise and nutrition that we can have to the best of our age. So what are the, when we say we need to maintain, why should we maintain? Because the consequences of muscle mass loss is much important. Because when we see all the intensive care unit patients, irrespective of the diseases, the mortality will increase, the infection rate will increase, thus the admission days and intubation ventilator days also will increase. The post-op, again, the mortality will come, the rate of mortality is higher, complications are higher, the length of hospital stay, and the long-term prognosis, the morbidities are, prognosis is bad and morbidities are higher for a person with a lesser body mass. And when we look at the systems, any systems, doesn't matter whether it's respiratory, cardiovascular, malignancy, gastrointestinal, any system, the outcome is bad for sarcopenic patients. And apart from these critical illnesses, they can go into depression, they can have lifestyle diseases like diabetes, they can have falls and fracture and other malnutrition associated diseases. So this is a vicious cycle. Inflammation due to aging, and this mTOR activity levels will go up, and all other inflammatory markers will go up. Sorry, the mTOR activity will go down because it's protective, and all the inflammatory markers will go up. Muscle protein degradation will happen as a result. Muscle protein synthesis will decrease, and again it will become a catabolic state and decrease of muscle mass. So this is just a practical guideline we need to have in our mind when we see our patients in a daily basis, and for us also to assess ourselves. So we should have a suspicion, and if we suspect, we can use the SARC-F score for that. It has five factors and 2 points for each. It's simple criteria. It's simple factors. We don't have to mention. It's just based on the history, whether the patient have increased sleepiness, tiredness, etc. And if it's the screening test is positive, then we have to go for a objective muscle strength assessment by grip strength, chair stand test, and then see. If that is low, or if that is suggestive, then sarcopenia is probable. We have to have radiological imaging to assess the muscle mass, and if that is low, then sarcopenia is confirmed, and we need to put him on the physical performance tests and start on rehabilitation and nutritional therapies. It's grossly looking at the same. I'm not going to the details. So different mechanism involved in sarcopenia is what has been already told, and the impact of this of resistance and aerobic training on the mechanism of sarcopenia. That's exercise will affect the hormonal changes back and impaired muscle blood flow, increase inflammation, decrease the mitochondrial function. It can have neurological changes. So decrease the sedentary behavior can result in sarcopenia, and sarcopenia will decrease our strength to do exercise, and again it's another vicious cycle. Just a few words on whether this supplementation of nutrients will help or not. So protein is very important, as well as many other micro and macronutrients. Protein, because when we look at it, usually we say 1 gram per kg is adequate for daily activity, but when we look at it, actually it is 0.8 gram per kg. But if we go, if we have some mild diseases like viral infections, we should target something like 1.5 gram per kg. If any patient in having a critical illness or in ICU, we should target higher. It should be something like 2.4 gram per kilogram. And when we say we need to build on the protein, we should understand that we should all be building on the fat and carbohydrate. Because when the fat and carbohydrate is not there, then protein is the next source of energy, and body will start, because all these are catabolic states. So the body will start consuming the protein whatever we have, and to keep the protein just for building the muscle mass. And we know that it's not just a muscle mass. When we say protein, majority of the protein in the body is as muscle mass. We know the enzymes, the receptors, the hormones, the inflammatory marker, the inflammatory agents. Many of these or most of these are proteins. So for body to have a normal homeostasis, we should have a normal protein levels, and to have a normal physical activity level, we should have a normal muscle mass. To keep the protein for that, and to avoid consuming protein for getting just the energy, we should have a carbohydrate and fat adequately. And then we should have other micronutrients for the adequate using of proteins, because studies have come up in carnitine. Here I'll be mentioning about HMB, but then carnitine is good protein sparing agent, because it will enhance the beta oxidation of fat for nutrients. So HMB is a activated metabolite of amino acid leucine, and occurs naturally in the body and found in small quantities in the food. So basically what it does is, this HMB is a metabolite of leucine, and it will prevent the consumption of proteins and increases the muscle mass. By age, it also deteriorates. How it helps in the molecular level is, it helps in the leucine, the 5%, the protein metabolite leucine, which is an amino acid, 5% of it is converted to HMB, and HMB will increase the mTOR, that will help in the muscle protein synthesis. It will decreases the NF kappa B molecules, which will help in the muscle protein, decreases the muscle protein that molecule will cause muscle protein degradation, and by negative feedback it will decrease the degradation. Clinical application, it will help in muscle mass and will decrease or curtail the vicious cycle we have already discussed about. Not going to the details of the same. So when HMB was given or substituted for patients, it is shown that muscle strength is high and muscle mass was better. So that will increase the lean mass, it will increase the hand grip, it will prevent the muscle loss in ICU patients, and the outcome, the morbidity and mortality of these patients in various studies has been better. So it's just summary. It's exercise and nutrition and maintaining an adequate muscle mass is important at every age for preventing morbidity and reducing the mortality in any of the diseases. And when we look at the COVID-19 patients, we had many of the patients coming with breathing difficulty, and many of them are not hit at the lungs, because all these viral infections usually affects the muscles. So the sarcopenia leads to when the lower limbs are affected with the sarcopenia, it's difficult to walk. Like that, if the shoulder and the chest muscles are affected, it's difficult to breathe. Just a typical patient in our OPD, no history of diabetes or hypertension. Patient was having history of frequent respiratory tract infections. Also had weakness, fatigue, and loss of appetite. Sedentary lifestyle. When we look at the nutritional assessment, sort of okay, but then he has some features of numbness and tingling, maybe of any of the neurophysiological vitamin deficiencies, and immunological evaluation sort of normal. And nutritional assessment revealed there's a nutrition deficiency. Hand grip dynamometer showed that weak muscle strength is there, and patient underwent nutritional education and asked to take the resistance training, and he was advised to take oral nutritional supplements for maintenance. And after 6 months, his appetite improved, and he has improvement in muscle strength, BMI improved immunity, and quality of life improved. Generally, the generalized weakness and the breathing difficulty associated with that also improved. So substitution of oral nutritional supplement for the adequate levels is important, but we should not rely on that. Person should take adequate nutrients by diet and do adequate exercise. Thank you.
I would like to invite all the doctors on the stage, the speakers of today especially, so that we can have a discussion and to clear the doubts.
Any questions, please?
We have a question on Zoom from Dr. Thomas M. David. Please give the contact. Please give the contact details of Matridon provider.
Contact details.
Matridon provider.
Matridom provider is by 3M KCI. So KCI WAC, negative pressure wound therapy. So maybe nearby they will have the KCI WAC. They normally deals with this Matridom, so they can directly deal with them.
And
If you want number, I can share the number later.
he also has another question. How is melatonin dressing sterilized? And one side seems plasticky, hence the question. Also, which side goes on the wound? How is melatonin dressing sterilized?
It is provided by Smith and Nephew groups of companies. It comes like a sterile only. It is already sterilized one. No need to sterilize it separately. It is easier to sterilize actually.
Okay, thank you. And I have a question. Patients often come to me with, blebs and all. After the burns, they come with blebs. So should these blebs be burst or should it be left alone to remain as such?
There are two schools of teaching in that, but the general consensus is that smaller blebs can be left and larger blebs need to be broken.
Okay.
It said that the blebs smaller than 1 centimeter can be left.
Okay.
But the problem is that if there are multiple blebs and the skin is still there, you cannot assess the depth of the wound. So usually it is that larger blebs, the deeper the wounds, the blebs will be large. This is not a hard and fast rule, but that is generally seen. Deeper burns will usually have larger blebs. So those blebs needs to be broken. The smaller blebs, if it's a very small area, you can keep it without breaking, or maybe you can puncture it with a needle and use the skin as a biological dressing there.
Okay.
If it is a smaller one.
Oh, that's
But a larger one, it is better to break it.
Okay.
You have to break it.
Another problem which we notice is like a pressure sore. When you see the pressure sore, it appears to be necrotic tissue. We have to remove it and then only we know what is the depth of it. Or else we cannot know the depth of it.
Okay.
And in the hands of plastic surgeon, it's better to remove it because we want to know whether it is a second degree superficial or second degree deep, or because for everything the management is totally different. So for a plastic surgeon as such, it is for a small wound or a remote area, they cannot reach the plastic surgeon, all these things. Yes, it's better to go by as Naveen says.
Okay. Also, should the skin, if we burst the wounds, should this skin be left on or should we cut off the skin? The skin, should it be removed, the loose skin?
The same thing I told. Smaller ones, you can puncture it and leave it as a biological dressing. But larger one, it is better that you remove it
The skin
And
also.
okay.
Okay.
If you are going to give an occlusive dressing, because larger, small burns, you can keep it open, but larger wounds, it's better that you always dress it. So if you're going to dress it, you can remove those skins.
Also, I have another doubt. How often to apply this silver sulfadiazine? How many times a day? It it be applied twice a day or once a day or?
It is said the silver as in the duration of action is smaller. So you shorter, sorry. So you have to apply it twice a day actually,
Twice a day.
but it is not practical. But silver sulfadiazine was a older thing. Now you have got colloidal silver, nanocrystalline silver, and even in this materials impregnated with silver, which can elute the drug even for 7 days. So I don't think now any plastic surgeon would be except in the remotest medical colleges somewhere where silver sulfadiazine may be used.
So, okay.
But we have all changed on to the next generation
Just
of
colloidal
silver
silver.
eluting.
So how
things.
often can it should be removed? Or
If it is the material like Acticoat, they have got of 3-day variation, 3-day, 5-day, and 7-day. So you can keep it up to 7-day, provided it is not an exudating wound. If it is an exudating, you have to use a Mepilex AG or something like that, which has a foam in that. Foam with silver dressings you have to use.
And also how to remove this, I mean, for the second dressing, what should you do with this? The ointment will all have dried up. So how to remove that? We can't apply on top of that. So how to remove that old dried up?
You can moist it.
ointment?
You have to moist it
Moist
and like Acticoat, you never apply normosaline with that because the chlorine and the silver forms and silver chloride in that. You're not supposed. So when you use an Acticoat, you always have to use distilled water along with it.
Okay.
And if you want to, you can always moist the wound
Okay.
before removing the
Before
dressing.
removing. I also have another question to Dr. Akhil. I mean, Ensure seems to be have all the proteins in a balance, they claim so. But what about whey protein? Does it have any problems? I mean, all the sports persons are taking it, you must also be taking it, I don't know. I mean, so does it have any problems, any renal issues if you take whey protein?
See, whey protein is milk protein. So when we say about the protein, all the differences, all the issues came with creatine, which is another way, which was another protein which has been used previously. So difference in action is the creatine will just pull the fluid to the muscle fibers and bulge it. That's why suddenly we'll get, if we use a creatine protein, suddenly we'll have a look of a muscle mass because it's all bulged up. But the problem is as it withdraws all the fluid, it will affect the fluid status of the body, hemostasis of the body, and that can affect the renal functioning, everything. Whey protein being a milk protein, it doesn't have that action. It will increase the number of fibers and hypertrophy the fibers by increasing the fiber mass itself, not volume. So whey protein is supposed to be better and of lesser side effect. Only side effect is if you take the protein beyond the level which your kidney can't handle. Otherwise, whey protein is safer.
Okay, and how much would you say is safer for the whey protein? Usually one takes 1 scoop 30 grams or so, right?
Yeah, if we are using it for maintenance, we can take 1 scoop a day.
Yeah.
If you are not looking for a muscle mass building. So if muscle mass building, we need at least 2 gram per kg. Usually 1 scoop will give 1 gram, most of these supplements. If we need a muscle mass building, then we need to take 2 grams. But then when you say 2 grams of whey protein, we are taking other proteins also in the diet. We should decrease, it's better to decrease that amount from this protein powder what we are using.
And they say that protein has to be taken within 15 minutes of any active exercise. Would you say that you should take carbohydrates also with it to increase the protein intake?
Carbohydrates.
Yeah, together with the protein to increase the protein absorption or anything. Is there anything like that?
Why we should take immediately within around 15 to 30 minutes of exercise is for the muscle mass hypertrophy. Because we have given enough resistance training for the, the increased load training for the muscles. And when the muscles is seeking for hypertrophy, then if we provide the proteins, it will help in the increased conversion rate to the muscle mass. And carbohydrates, it's a easy currency for energy. So ideally say it's better not to do exercise in empty, empty stomach, not immediately after taking food, but then the easy currency should be always available for consumption. But then when we say using the protein, immediately if you do exercise now and we are run out of carbohydrate, immediately it won't take from the protein, from the chronic
From the
status.
carbohydrate. Thank you. Anyone else has any doubts? No, sir.